This is SSN.
Story Studio Network.
I'm Tom Hoppe, and I'm your host of the Most Painful Podcast. Welcome to the Most Painful Podcast. I'm your host, Tom Hoppe. On our last episode, we spoke with Deb Denman about research and knowledge mobilization. Deb spoke about knowledge mobilization and how it can help summarize key findings from, say, a 100-page research paper to make it easier to absorb the information and shorten the length of time it takes research findings to get into practice. If you missed this episode, you can listen to it on our Spotify and Apple feeds. And if you want to get notifications for the most recent episodes, subscribe to the podcast. In Season 3, we had an episode on osteoarthritis. Arthritis seems to have an impact on a lot of people, and we've had many requests from our audience to have more information about arthritis and how to better manage it. Today, I'm joined by Dr. Max Sun. He's a clinical assistant professor at UBC Department of Rheumatology, also a clinical teacher in the pain program at UBC here in Vancouver. Max, welcome to the show.
Thank you, Tom. Thank you. It's good to be here.
Thank you, Max. Well, arthritis, I guess you and I have talked a little bit about it offline, and it's a fairly broad topic. Is that correct? Is there a lot of areas that arthritis can affect somebody?
Yeah, most definitely. There's actually hundreds of different kinds of rheumatic disease, many different kinds of arthritis, and it affects a large proportion of the population in North America and all around the world. It has the most common types that we associate with are osteoarthritis, which your guest spoke about last time. But that's most when it comes to pain and pain-related issues. In the rheumatology field, which is a field that I normally work in, we also look at inflammatory arthritis, or what we call autoimmune inflammatory arthritis. And that includes arthritis such as rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, etc., etc. And that type of arthritis is a lot less common than osteoarthritis, but it can have similar or even more morbidity. It can have more impact on patients' quality of life and functionality. And the two are interconnected because the more type of autoimmune inflammatory arthritis you have, the more likely that the joint being affected will develop osteoarthritis in the future, and then that may propagate to chronic pain over time.
So which comes first? Is there a progression where OA comes after, or does it matter? Like, can osteoarthritis be something on its own, or is the inflammatory arthritis lead up to OA?
It's both. So osteoarthritis can certainly affect people without having inflammatory arthritis. And inflammatory arthritis can affect people before they develop osteoarthritis, in which case it can accelerate the development of osteoarthritis in certain joints. It can also affect people who already have osteoarthritis. So it can be all three.
So these are types of arthritis, like, keep it simple, I guess, for myself and other people. It's like arthritis you'd have in your hand joints, or arthritis you would have in your knees, and it's inflammation. So what's happening in the body to cause that type of inflammatory arthritis?
That's a great question. We have a lot of theories. We are not 100% sure. We suspect that in terms of these autoimmune inflammatory arthritis, it is a combination of genetics that makes people have that risk factor, predisposes them to develop these types of inflammatory arthritis. And then by a combination of external factors, it certainly can propagate or cause a flare of such inflammatory arthritis. For example, we have found that there are genetic markers that can be associated with rheumatoid arthritis. There may be a familial component. It does not mean that if your family have it, then you will have it. And it does not mean that if your family doesn't have it, you'll never get it. But if your family does have a history of it, then you are more likely to have it. It does increase that risk. Additionally, we found that certain external factors, such as smoking, poor dental health, can actually increase your chances of developing these types of autoimmune inflammatory arthritis. And that's actually a really big and wide topic because right now in the world of rheumatology and pain medicine, there's a lot of emphasis on diet, healthy living, and all that kind of stuff to see if that can influence and decrease the risks of developing these autoimmune inflammatory arthritis and develop other type of pain components. So that is still under active research. We do know that certain diet, like a anti-inflammatory diet, can potentially decrease your risk or decrease your risk or decrease the intensity of your inflammatory arthritis, especially if you're healthy. But we're not really 100% sure on how much of an impact these will have and which specific types of foods will give you the biggest impact. And that is still under investigation.
Now, I mean, we talk about food, we hear about sugar being one of them. Is that a myth? Is that under investigation, or is that a confirmed hypothesis that sugar can affect arthritis?
It's confirmed that sugar can affect arthritis, but in an indirect way, from my understanding. Sugar increases glucose intolerance, sugar increases weight, increases BMI. And what's interesting is that people who are heavier, people who have higher body mass index, people who weigh more, and people who have increased abdominal girth, they actually have a higher risk of developing certain types of inflammatory arthritis. The one that really comes to mind is psoriatic arthritis. And this is arthritis that's like inflammatory autoimmune arthritis that affects people who also have psoriasis. And in this case, there's been many studies that show that these patients are usually overweight. They also have fatty liver, and they also have other metabolic syndromes like glucose intolerance, high blood pressure, etc., etc. And it also increases their chances of developing psoriatic arthritis. And what we discovered is that these patients who are less healthy, who are heavier weight, who have all these comorbidities, it's actually harder to treat their inflammatory arthritis compared to those who don't. And there's actually been studies to show that if you decrease your weight, whether it's decreased fatty food, decreased sugar, if you decrease your weight, the effect on your disease is the same as taking an additional anti-inflammatory or autoimmune medication to control your disease, which is quite significant.
That is, because my understanding of taking medication has its impact on metabolic health as well. So could it become a vicious circle with this? You're trying to deal with someone's arthritis if they have poor metabolic health, poor diet, and now they're taking medication as well.
Sometimes it can certainly be that way. And so when I see patients, especially those who are overweight with psoriatic arthritis, I do counsel them to try and decrease their weight, eat more healthy foods, because with these types of metabolic derangements, such as fatty liver, high blood pressure, etc., it does make it more difficult for us to treat them because, as you said, a lot of these medications that we use to control autoimmune disease can affect other organs, liver, kidneys, so we really want to get that under control. In addition to that, we discovered that it's not just inflammatory autoimmune arthritis that could be affected by a diet and by weight. We find that even for people with osteoarthritis, which traditionally has been taught as a disease of age, as a disease of overuse, that there is also a component of inflammation that can accelerate osteoarthritis that is not the same inflammation as rheumatoid arthritis. It's to a lesser level. And so that type of inflammation can still drive osteoarthritis. And that's especially true for hand osteoarthritis. We have patients who have a lot of hand pain, hand osteoarthritis, and they have no history of rheumatoid arthritis. They have no history of trauma, but they have hand OA. They don't work as a masseuse. They don't put a lot of pressure on their hands. Why do they have it? Part of it is also genetic, but part of what we find is that there may be some low-grade inflammation that is causing progression of this osteoarthritis. And we also discovered that some of this inflammation comes from the fat cells in their body. And so when I see patients who are overweight, they have OA of the knees, they have OA of the hip, but they also have hand OA. I tell them, we can't prevent OA, we can't treat it yet, but one thing you can do to help and maybe slow down the progression is to lose weight and to eat healthy. And that can certainly help decrease the progression of hand OA in many instances.
And if we look, I know the veteran population has a lot of arthritis OA at a younger age. And that's probably just from use, I would suspect. Overuse. from
I think
heavy
so.
loads?
I think it depends on where. I think if it's a lot of overuse, you would see it mainly in the knees and in the hips, maybe in the back. You know, but if it's in the hands, there could be overuse if they do a lot of dexterity type of work. But a lot of times it could be due to other causes as well for hand OA.
So somebody who has a good BMI, relatively has good metabolic health, but they still have inflammation. Is that now genetic, or is that overuse, or is that coming from somewhere else in the body? I mean, diet's one of the things, but say they have a good diet and everything's healthy, but they're still struggling with that. What could be causing the inflammation there?
That's a very good question. It could be any of the ones that you mentioned. It could be genetics. It could be that they have a autoimmune disease underneath that's driving the inflammation. And, you know, we put a lot of emphasis on healthy diet, healthy living, good BMI. But the fact of the matter is, if you actually do have an underlying autoimmune disease, it can affect you even if you're doing everything else perfectly. Because part of it is genetics, part of it is maybe environmental trigger. It doesn't have to be smoking. You could be a non-smoker. You could have very good dentition. Your teeth could be perfect, but maybe you get a viral illness that you may not be aware of, and it kind of activates your immune system and it causes this type of inflammation. And so you could be perfectly well and you could do everything right and you could still have this autoimmune inflammation. But that's autoimmune inflammation from autoimmune disease, rheumatoid arthritis, lupus, psoriatic arthritis, ankylosing spondylitis. A lot of people tend to use the word inflammation, but much more broadly. And that is more difficult to ascertain because it's hard to measure the feeling of inflammation. I'm not sure if anybody's ever told you that they feel inflamed. Mm-hmm. But when we measure inflammation from a rheumatological point of view, we really measure the markers such as C-reactive protein, ESR. Those are our measurements of inflammation. And if you have a lot of inflammation, they should be high. But a lot of times when people feel like they have inflammation and we measure them and we don't detect anything and we do a physical exam and we don't see any active inflammation, it's really hard for us to tell them where their feeling of inflammation comes from because it's really hard to detect and it's really hard to determine.
So then something like stress, for example, would that cause inflammation to increase? And would that affect arthritis as well? Or is that more of a mind thing versus an actual physical reaction?
Stress can actually worsen your arthritis and it can worsen your pain as well. Whether stress itself can actually cause a detectable increase in your inflammatory markers, I don't think so. But there has been some studies to show that stress can potentially worsen inflammatory arthritis, but it can definitely worsen the pain and disability associated with inflammatory arthritis and osteoarthritis.
Yeah, so we see that in some veterans, and I guess you may see that in some patients as well too. If someone's having, a bout of stress or PTSD or something like that their chronic pain can get worse, and it can also, if they have arthritis, I guess that would be impacted as well.
100%. And so when shifting gears now to the chronic pain aspect of arthritis, osteo, and inflammatory, we see that there is a lot of other predisposing risk factors that can increase a person's chance of developing chronic pain from osteoarthritis or rheumatoid arthritis. PTSD, psychological stress, adverse childhood events, and adverse childhood events, there's been a study on it called the ACE study that looked at the correlation between adverse childhood events, which includes stuff like domestic abuse, abandonment, physical, mental, sexual abuse, and the propensity and the probability of developing chronic pain later on. And there's a very large correlation. And so when I see patients in the chronic pain clinic, I see all types. And a lot of times I see patients with osteoarthritis, but their pain associated with their osteoarthritis is really out of keeping with the physical exam and the degree of damage of the osteoarthritis. Additionally, I do see a lot of patients with rheumatoid arthritis, lupus, and ankylosing spondylitis. And again, their pain is out of keeping with the level of disease activity that we detect. And so we really have to look at chronic pain as another layer of complexity on top of these patients, where treating their osteo and treating their rheumatoid doesn't take away their chronic pain completely. Because while those issues may be one factor in the propagation of their pain, the self-perpetuating cycle of chronic pain has already been established, whereas taking away that aspect, that active inflammatory or active osteoarthritis aspect, doesn't necessarily take away the rest of the pain that they feel. And then those patients can be very difficult to treat, and they're the ones that usually have a lot of PTSD, stress, adverse childhood events.
So are there studies out there that support that things like yoga or mindfulness help reduce the inflammation or reduce the effects of arthritis if it's caused by inflammation, if I'm hearing you correctly, with people who have higher stress?
So I think it's important to define what type of inflammation that we are talking about, because different fields use inflammation in different ways. In rheumatology, when we look at inflammation, we really look at high CRP and ESR for rheumatoid arthritis, lupus, psoriatic arthritis, ankylosing spondylitis. And in those cases, yoga can help with mobility, can help with pain, can help with their recovery, but it doesn't really decrease their inflammation or control their active disease. For that, you really need medications. Some people also add on a little bit of dietary changes, healthy diet, weight loss, medications, but it's really the medications to help decrease that autoimmune flare, that autoimmune inflammation activity. When we look at chronic pain, some people will use chronic pain, will use the term, neurogenic inflammation, or, it feels inflamed. It feels really painful. It feels really inflamed. But a lot of times we can't detect any appreciable inflammation in the blood work. And so in those kind of situations, can yoga, mindfulness help decrease the sensation of inflammation and decrease pain? Yes, there has been studies to show that there has been some benefit. Any of those treatment modalities by itself potentially has a slight benefit. You really have the added benefit if you do many of them together. You have to do mindfulness, gentle exercise, yoga, deep breathing, de-stress, proper sleep. You really have to put them all together to help break the cycle of chronic pain and bring it down, and hopefully decrease the sensation of inflammation. And this inflammation many times is really not detectable on blood work. It's more of a pain associated feeling of inflammation. And so we just have to make that clarify that difference.
Yeah, and that's very helpful. So when we look at OA or RA, does exercise like high intensity running, zone 2 workout, weights, that kind of thing, does it help reduce some of the symptoms, or is it once you have it and it's just going to progressively get worse and you're eventually going to end up on medication?
I think you made a very good point, and the point is, does it decrease symptoms? And the answer is, for osteoarthritis, yes, it does decrease symptoms. It may not help bring back the cartilage that you lost. That has already been gone. We don't have any treatments to help bring back the cartilage or quote unquote heal osteoarthritis. But if you are able to do those kind of activities and you are able to strengthen the muscles around the joint that has osteoarthritis, then yes, a lot of people will feel improvement in their osteoarthritis-related pain. The joint gets more stable. They have more muscle mass. They have more stability in the joint. They feel less pain. That's for osteoarthritis, and 100% yes. Now, for rheumatoid arthritis, the answer is not really, no. When you actually have a flare and you're having an active inflammatory process in rheumatoid arthritis, psoriatic arthritis, in those arthritises, just doing exercise doesn't bring down the inflammation. And at times, when you try to push yourself too much, you can actually cause more damage to the joint that is actively swollen, actively inflamed in the rheumatological sense, because there's a lot of inflammatory cells, a lot of inflammatory cytokines in the joint. And if you're using it too much and you're doing more than what you should and you're pushing yourself too much, it can actually theoretically cause a little bit of damage to the joint. And so for people with rheumatoid arthritis and psoriatic arthritis, my recommendation is always, we have to treat the inflammation first. And once the inflammation is well controlled, then you start on the exercise. Then that's where it's going to be helpful in getting you back to your previous pre-disease state. Because what happens a lot of times is patients get rheumatoid arthritis, patients get psoriatic arthritis, they stop moving because it hurts. They are not as active as they used to be because they're tired because of the active inflammation in their body. And especially in older age groups, they have very fast sarcopenia, which is a term for muscle loss. Their muscles lose mass really quickly with immobility. And so sometimes when we treat these patients and we treat their inflammation, we control their rheumatoid, we control their psoriatic arthritis, they still have pain, or their function is still low compared to before, or they still have more fatigue. And that's what we ask them. You have to really go through the steps that you mentioned: aerobic exercise, weight-based exercise, to bring back your muscle strength to go back to the level it was before. The only caveat is a certain disease called ankylosing spondylitis. It is an inflammatory joint disease that affects the spine. And it can occur in other diseases as well. But for this specific disease, the first line therapy is actually range of motion exercise of the lumbar spine, yoga, maybe Pilates, but range of motion exercise for that specific disease only can certainly help as first line.
Yeah, which is interesting because I think of, we talk sometimes about veterans on this show with the military mindset of just pushing. And veterans who've gone in interdisciplinary clinics, from some of the research that we looked at, they just push and they have peaks and valleys. So I like how you put that, is that you need to stop first, get it sorted out, and then work your way back to where you were, versus the other way of just pushing through the pain, and then the individual has a bigger problem, from what I'm saying.
Yeah, 100%. And I think that's the case in rheumatology and the case in chronic pain as well. And I think it's important for listeners to know that, look, a lot of veterans and a lot of my chronic pain patients are really high achievers. And they set the bar for themselves very high. And many times they're able to reach that bar. And when they're not able to reach that bar, when they're sick, when they have an injury, when they develop rheumatoid arthritis or whatnot, it kind of makes them feel, it kind of brings them down. It kind of makes their mood go low, and they think, hey, why am I not able to get to that point? And they push themselves really hard to get to the point. And in many cases, if the diagnosis is not certain and they push themselves too hard, you can certainly cause more damage than if you just wait, take a step back, rest a little bit, see the right specialist, get the right diagnosis, get the right treatment, and then slowly push yourself way up, because that is the better way of going forward.
And I agree with that. And I struggled with that on my own journey, because it's just a lack of knowledge. I mean, it's one of the reasons why I'm doing this podcast, is to provide that, exactly what you're saying, is that type of knowledge. It's to go that way, because it's like a light switch. You just start getting on a treadmill or whatever, and next thing you know, you're running at full tilt. And,
that's it.
And then you stop, and it's like, ouch.
And it's hard for people who have been doing that for most of their lives to change gears, and it's hard to convince them to do so, because they'll say to themselves, hey, look, I don't want to be soft on myself. I want to be able to push, but many times that's not the right way to heal.
So we have 30 seconds left. What would be one big takeaway you'd want to give to the audience?
One big takeaway is, from everything I said, I think, is have a healthy lifestyle. But if you feel like there's something else going on, seek help soon and get the right diagnosis before doing any type of self-directed treatment, because I think it's important to get the right diagnosis first, and then work with your healthcare providers to develop a good plan to get back to where you are before.
Well, Max, that is excellent information. I really enjoyed the discussion, and I'd like to thank you for being on the show. I think a lot of people will walk away with some good knowledge today.
Thank you. Thank you, Tom.
On our next show, we'll be talking to Dr. Martin Gibla about high-intensity training and how it can help cardio health. So hit the subscribe and like button. This way you'll get the latest episodes. For feedback about the show or more information on chronic pain, you can visit our website, veteranschronicpain.ca, or follow us on Facebook and Twitter at chronicpaincoe and on Instagram at chronicpain_coe. Once again, Max, thanks for being on the show. For the audience, stay safe and keep the hope alive.
The Most Painful Podcast is produced for the Chronic Pain Center of Excellence by Story Studio Network.